Welcome to Language Access Matters, the podcast that dives deep into the crucial role of language access in public services and businesses. I am your host, Carla Velandia, and I invite you to join me on a journey of discovery and empowerment. Language access is not just a matter of convenience. It is a fundamental human right and the key that unlocks doors to essential services and opportunities. In this podcast, we'll explore the far-reaching impact of language access, examining how it shapes not only healthcare, justice, and education, but also the world of business. Through thought-provoking interviews, insightful discussions, and compelling stories, we will unveil the power of language access. We will hear from professionals who bridge communication gaps to provide quality care for diverse communities. We will explore the intersection of language, law, and justice, and the crucial role that interpreters and translators play in ensuring fair and equitable treatment. We will delve into the challenges and innovations, as well as how language access opens doors to effective communication and inclusion, and how it makes our society more equitable. But our exploration doesn't stop there. We will also uncover the profound impact of language access in the world of business. We will hear from entrepreneurs, industry leaders, and experts who understand the value of inclusive and effective communication and how it drives success in today's global marketplace. Language Access Matters is your platform to understand the significance of language access in these vital sectors of society. We will shed light on the barriers faced by individuals and communities and the innovative solutions that promote inclusion and equality. Whether you are a healthcare professional, a legal expert, an educator, a business owner, a linguist, an advocate, or simply passionate about the power of language, this podcast is for you. Together, we will navigate the challenges, celebrate the victories, and advocate for a world where language access truly matters. So, join me on this enlightening journey as we uncover the impact of language access in healthcare, justice, education, and businesses. Let's amplify the voices of the 25 million people that don't speak English in the United States and those that don't speak the dominant language around the world. Those voices deserve to be heard and empowered, and we need to empower ourselves to build a more inclusive future. Welcome to Language Access Matters. Let's embark on this transformative exploration together. Good afternoon, everyone. Today we're with Carla Fogaren. I am very excited to have her here today. She's one of my heroes and inspirations to pursue language access. Carla has served as the System Director of Diversity Initiatives, Interpreter Services, and ADA/504 and Section 1557 Coordinator for 42 hospitals, 6,000 providers in 11 states. Carla is known nationally as a pioneer in the field of medical interpreting, as well as a national consultant on language access, health disparities, disabilities, and regulatory requirements for hospitals. She had created and implemented bilingual clinical staff language assessment to comply with Section 1557. Carla has performed over 60 gap analyses for hospitals and clinics to assess compliance with Joint Commission, DMV, ADA, and other federal and state requirements. She was one of the 13 participants that helped create the International Medical Interpreters Association's Standards of Practice. Carla helped to promulgate the interpreter law in Massachusetts, requiring all hospitals to provide interpreters, as well as being a founding member of FOCIS. She is currently the Vice President of the National Council on Interpreting in Healthcare, NCHIC. Welcome, Carla. It's such an honor to have you here.
It's my pleasure. Honestly, thank you, Carol, for having me. I'm very grateful for all the work you do in bringing more awareness to our field.
Thank you so much. And tell me, well, tell our listeners now in your own words, what do you do and what are you working on these days?
So, a little bit about me personally. I was born in Angola and raised in South Africa until the age of 12 when I immigrated to New Bedford, Massachusetts. And then I became a registered nurse. And because I speak Portuguese, I was constantly pulled into interpreting. I soon realized how little I knew and that I was completely out of my comfort zone. And I approached my chief nursing officer to ask if we could create an interpreter program at the hospital. She said yes, and she told me, hey, go research it and create a business plan. So that one program of me still doing nursing and doing part-time interpreting ended up actually growing for me, overseeing 42 hospitals in 11 states and over 3,000 physician practices. And in that role, I spent over 30 years of my career doing. I was responsible for language access, Section 1557, diversity education, and I was also a certified ADA coordinator. But I just left that, Carol, last May of 2022 after 34 years. I decided that I wanted to move on, leave what I had helped create with the fine team that I had, and then take some time off for the summer. And then I started consulting in healthcare. So I currently consult nationally on topics related to language access, disparities, health equity, regulatory compliance, gap analysis, things of that nature.
That's wonderful, right up my alley, and definitely the topic of interest for this podcast. And Carla, I've always admired you because you have been a powerhouse, and that's in fact the reputation you have. And you're a great advocate of language access, as we just saw the description of what you do, especially in healthcare. So I'm interested to hear your story and how you became part of this topic and this conversation on language access.
Well, I think like most of us who happen to be immigrants and children of immigrants, right? Kind of become chameleons between both cultures and languages. But I will tell you that I've always been an advocate for those who cannot speak or help themselves. But being an immigrant, especially from a country like South Africa, who at the time was having a lot of struggles, uh, so that gave me a little bit of a different perspective. Coming to the US was kind of a traumatic transition for me because of where I was and where I was coming. And I was 12 years old. So face it, that's a very difficult time anyway. But I will tell you that what really brought it home for me was I came at 12, and when I was 14, I'm the oldest of three girls. My dad, at the age of 43, started experiencing some headaches. And he was a welder for the boats, the fishing vessels in New Bedford. And his headaches were getting really, really bad. So he went to go get checked, and he was diagnosed with a brain tumor. But how I became involved was they ran so many tests in a hospital in southeastern Massachusetts. And my mom, my sisters, my grandmother, my grandfather, my godparents from confirmation, the whole busload of people that we have with us sometimes. We're all in the waiting room to hear what was happening when the doctor and a nurse came down the hallway. And both my mom and I could hear them saying, I wonder if anybody in this group speaks English. So my mom, who speaks 7 languages fluently, she really is a linguist, stood up, all 5 feet of her, and she could not speak in any other language but Portuguese. She was such a wreck. So as a 14-year-old, I got up and I said, I speak English. And he proceeded to ask me to tell my family that my father had a terminal brain tumor. And I remember as a 14-year-old being kind of proud of the fact that I kind of knew how to say those words in Portuguese, not realizing the message that I was conveying, literally a death sentence to my family about my dad's condition. So, you know, he died 3 months afterwards. I will tell you that I don't think I really felt the impact of that. I mean, his death was horrific, but it was the way my grandmother looked at me after that. It's almost like she kept hearing my message over and over again that I was the one to tell her that her son was dying. And right after they had me tell them that, they also said, and we have to have you take him home because it was the flu epidemic of 1977 and we don't have room for patients we can't help. So,
How terrible. I'm so
yeah,
sorry.
it was pretty terrible. But, then I got this visiting nurse because this was before hospice. I got this visiting nurse that came to the house that was phenomenal, absolutely phenomenal. And she inspired me to become a nurse myself. So I decided to become a nurse, and I ended up working in a hospital in Stoughton, Massachusetts, that we refer to as Portugal because it's all people from Portugal. And as little as I knew medical terminology in Portuguese, because I was raised by Portuguese parents, but I wasn't raised in a Portuguese speaking country. I was raised in South Africa, so Portuguese was literally my third language, not my first language. I mean, it was my mother tongue, but it's not the one I used most commonly. I started being called upon to, quote, help patients with Portuguese to interpret for them. And that's when I realized how little I knew and how dangerous I was being without having the right skill set. Because you don't talk medical terminology at the kitchen table. You'll say, "Ma, pass me the chicken." You don't talk about cholecystectomies and salpingo-oophorectomies and any of that. So I had to really learn what it was like to become more educated as a medical interpreter because I knew the terminology in English as a nurse, but I certainly did not know it in Portuguese.
Well, you have touched on so many things, Carla, from having to interpret as a child for your own family, having to deliver such bad news to your family, and basically creating this image of you, a member of their family, delivering this terrible news to them. So the trauma around that, and also the fact that your mother, who was a polyglot, could not speak any of the other languages but Portuguese
Yeah.
because of the level of stress she was facing in that situation. And also, as you say, the fact that you spoke Portuguese and learned it from your home, the kitchen, and all that, that didn't give you enough tools to actually help the community. Wow, that example encapsulates so many things that are issues in our language access or lack thereof in our country, right? And especially in healthcare, it continues to create challenges for diverse communities. And you had the experience like from being an interpreter and then to become an experienced executive in the healthcare space and known for building consensus around language access initiatives. So, can you tell me a little bit about this and maybe how your experience, the one that you just described, or all your experiences, factor into really building such consensus? What was the secret sauce that you have?
Well, I have to say, what you don't know, right? And if I knew the secret sauce, I would have bottled it and I promise I would have shared it. I was very, very fortunate at my last position. As the only job description that was ever given to me or written for me was the one of registered nurse, the one I applied for. Okay, so imagine I had numerous jobs over the 30 years, and the only job description that was ever written for me was that of registered nurse. All of my other jobs, community outreach, interpreter manager, directive and executive director, section 1557 coordinator, ADA coordinator, um, all of that I wrote myself.
Wow.
So the reason that I was successful is because I could define the scope of what I wanted to do. No, it was honestly because I felt like they had either enough trust in me to know what I needed to do would be what I would do, or to be honest with you, they really didn't know what they didn't know and just left it up to me to make sure that things were okay. I don't know to this day. So I wrote myself the job descriptions, which gave me a lot of leeway to focus on the things I thought was important. And to your point, Carol, for me, the most important thing that I believe has served me well is just being honest, mean what you say and say what you mean. I always use that phrase. I'm the type of person that's a perpetual learner. And if you want to lead in anything, you should try to become a subject matter expert, or if not, surround yourself with subject matter experts, right?
Totally.
Um, and with me, I think that with credibility comes confidence and trust. And I felt that over the years, I was able to gain respect, not only from the administration, but more importantly from my peers and a team of 150 interpreters and 7 managers. And you're only as good as the people that surround you. I honestly believe that. But being an RN certainly helped me. I will tell you that there were days, how you go in the hospital, you actually see the nurse's ID badge and it says another ID badge, in big letters says RN or
Yes.
MD. I would
Hmm.
literally put that badge on if I had to present to doctors or certain groups of nurses because they would listen to me differently than if I had gone in there as the director of interpreter services.
Totally. I think that carries so much power and credibility.
Yeah.
And, but also the fact that you have walked the walk, right? The fact that you have been an interpreter and been in the trenches, at least for me, in my professional experience, I tend to respect more a boss or a supervisor that is willing to roll up their sleeves and work alongside with me than a supervisor that's trying to impose something that she doesn't know, you know.
I totally agree. And the most impressive boss, as far as that I ever had, was this chief nursing officer that came into my office. I was reporting to her, and she came into my office like the second week she was there, and she said, "Carla, could you assign me to one of your interpreters? I want to shadow them for 2 hours."
Yes.
And I almost fell off my chair. I said, "You want to do what? What?"
Yeah.
So I assigned her to one of my interpreters who happened to be multilingual, trained in 2 or 3 languages, 3 languages at the time. And she came back 45 minutes later, sat in front of me and said, "Oh my God, I'm done. I can't keep up with this. This is ridiculous. You guys are super
Exactly.
busy." But
Mhm.
that's what it took, is for someone to actually not walk in my shoes, but walk along with us in our path of what we do as part of the clinical team for patients, right? And
Mhm.
I developed such an incredible respect for her because it's the first time in my whole career, and the only time, by the way, that
Mhm.
anybody has actually done that.
Yeah, but I really think that's how you really understand what happens at any level of the organization. And I'm sure not everybody can afford to go and shadow every employee, but the fact that she wanted to do that
Yep,
shows a lot about her leadership.
I agree. Totally agree.
So you've been, as you said, you work for 30 years in language access in the healthcare space. Can you tell me or tell us about the evolution of language access in healthcare? How did it become important?
So I have to tell you, I'm beginning to feel like a fossil, like a dinosaur that's being dug up.
No.
Because when I think back on it, Carol, it just seemed like yesterday that I was driving myself with a colleague, Natalia Konarski, up to Boston to attend an MMIA, the Massachusetts Medical Interpreters Association meeting. We had never been out to Boston. We like got lost like 3 times. It was before GPS or anything like that. So, luckily for me, I happen to be in the right state, right? So, as you know, Washington and Oregon and Massachusetts, we've had interpreter services probably the longest in the country. So, interpreter services have been in Massachusetts for at least over 40 years. And in 1988, the IMIA, which is the former Massachusetts Medical Interpreters Association, I happened to become vice president of that a few years later, set up this organization for interpreters. So I was in a perfect place. First of all, very heavily Portuguese speaking, which was my language, right? State that's relatively friendly to immigrants and refugees. Then this organization gets formed. And I think that because of immigration, refugees from all over the world, this really increased the need for medical interpreters, right? So it was just a perfect storm here in Massachusetts. And I think over the years, it became more and more evident that communication, at least effective communication, was an essential component of healthcare. Heck, it's a basic human right. Think about it. Human rights include communication regardless of race, sex, nationality, ethnicity, language, or religion, or another status. You can't discriminate. And how can you even take care of patients if you can't communicate? How can a patient access information? How can you make an informed decision that could save or kill you? Um, in healthcare, I mean, you just can't. So, as healthcare professionals, I think it's evolved tremendously. I don't think any of us as healthcare clinicians get up in the morning, Carol, and say, I can't wait to tick off my first Latino patient. You know, I think we all have the oath that we want to do the right thing. And honestly, it's become much more challenging. That's one of the reasons I left where I was for 30 something years, is because I could see that it was becoming much more challenging, and I wanted to be able to go into other areas where I could maybe impact change in that. So, people are leaving the hospitals. We should be keeping patients out of the hospitals. They're leaving the hospitals and coming back in the revolving door because they don't have the right discharge instructions and the right languages that they can understand. And how many times, Carol, have you and your team heard, oh, they're so non-compliant? Well, they're not non-compliant. They just don't know the rules of engagement because no one has explained to them what they should do, when they should do it, and who they should follow up with. So, it's crazy. It's not that difficult a solution, but it does take time, money, and most of all, empathy to be able to proceed and grow in this field.
And a couple of things you've mentioned that I would love to comment on, and is the fact that even though communication is such an integral part of healthcare provision, right? I just wanted to tell you that that is kind of the main thing I promote in the course I created, Effective Inclusion Through Language Access, is how communication is a key part of the code of ethics of all of the professionals in the social sciences, right? Any doctor, any nurse, any pharmacist, any social worker has a canon that talks about communication, any lawyer, right?
Yep.
And yet, when it comes to the population with limited English proficiency, is like, yeah, with them, the effective communication doesn't count. It's
Right.
such a contradiction, right?
Well, well, we become veterinarian medicine. You know
Exactly.
how I mean, I swear my dog can talk because she's so smart. But in all honesty, as an ER nurse many many years ago, there were many times that I'd have to treat patients without even being able to speak to them because they were in a trauma, right? So they were
Right.
unresponsive. but that should be the outlier.
The
That shouldn't be
only
the
thing, the
norm,
only,
right? that,
exactly.
that shouldn't be the norm. And for somebody to think that my mom can do with less, simply because she's, and she is an LEP, she speaks English, but if she was LEP, you know, that's just, it shakes me to my core, because at the end of the day, you always have to say, what if this was your mom, your dad,
Hmm.
your loved one, your child? Is it
Right.
okay for them to get less than just because you can't understand them? you know?
Exactly. It's the onus is not only on the fact that they don't speak English. The onus should be on you also as a professional. You cannot understand the person with limited English proficiency, and you
Exactly.
cannot just ignore that. Very well said. And also, as you said, it needs to be a perpetual reminder of the rules of engagement.
Yep.
And so, in your professional journey, what kinds of changes and implementations were you able to promote in that space in healthcare?
Well, I have to say, when I look back and when I was thinking of leaving, it took me a good 6 months to make that decision. I really wanted to finish certain initiatives that I started, that I felt that I owed it to my patients and to my team and to myself to complete. But just to be clear, none of the things that I've accomplished professionally were done only by me. It really takes a whole village, constantly negotiating, mediating with colleagues to make necessary changes. I had such a fun and incredible journey with so many people to thank for believing in me. And together we made many, many changes that have sustained. One of the greatest opportunities for me was to work with a group of people and Maria Paz Avery to create the IMIA standard of practice. That was many, many moons ago. And I also was very proud to establish FOCUS, the FOCIS, which is the Forum on the Coordination of Interpreter Services in Massachusetts. It's been in place for 16 years and it's still running strong with great leadership. So as medical interpreters or as translators, we have organizations like the IMIA, CHIA, TAHIT, ATA, etc. But what became evident to me is I had 6 hospitals at the time that I was overseeing. It grew to 42 in 11 states by the time I left, but I had 6 hospitals, and I had arranged for us to meet as managers once a month to discuss best practices, challenges, how to work together, share information. And other hospitals outside of my system got wind of it and wanted to come to our meetings. And I said, well, you can't come to our meetings. This is like an internal hospital meeting. And then I started realizing that that's the thing that's missing. We, as supervisors, managers, coordinators, VPs, directors, or whatever we call ourselves of language access services, really had no place where we could come together, support each other while learning best practices and sharing things with one another. So the first meeting I had, I invited everyone. I was doing cold calls, Carol. I was like, hi, this is Carla. And people were thinking I was selling something. And I said, if you want to come to this meeting, there's only one requirement. So it was a pretty funny day when we had this meeting. I said, the requirement is that you have to bring something to share. So, a policy that you created on language access, a guideline, a best practice, anything, but you have to bring it with you to share with the other hospitals, some of which are your competitors. And it was hysterical watching 2 VPs walk across the room to the show and tell table and begrudgingly pry the document off of their death grip because they were like, I don't want to share this. And then I just said, would you like to continue to do this? And they all agreed. And we have met every 2 months for a 3.5 hour meeting in person prior to the pandemic. And now it's obviously by Zoom because it's just easier. And we've actually expanded this. So it's not just Massachusetts, but it's gone national. So it's an incredible resource. If anybody out there is interested in it, feel free to email me at carlafogaren@gmail.com, and I'll introduce you to the membership committee person. And here's the best news. It's free. So there's no membership fees, there's nothing. And from a patient care related perspective, I will tell you that this was really important to me because you're only as smart as the people that you work with, right? So think about if I had an issue, Carol, and I wanted to know how to solve working with a patient who was deaf that was also a quadriplegic, right?
Mm-hmm.
You toss that out there and you have 15 wonderful experienced people responding with suggestions.
Mm-hmm.
So we never felt the competition. We always worked well together, and they are really, truly a great group. And the requirement is that you have to be a manager or somebody in leadership overseeing language access. We didn't want interpreters in the group. We didn't want the state. We didn't
Mm-hmm.
want Joint Commission. We didn't want LSPs, nothing personal.
Mm-hmm.
But we wanted this to be truly a very organic, safe place where we could talk openly about things. So that was one of the things. The other thing that comes to mind is that,
If I
work.
may say something though before you continue, sorry, I don't mean to interrupt you,
No, no,
but
no, go right ahead.
it is really great that you have all these different stakeholders that have to tackle a common problem, and that's perhaps what goes behind the idea of not having any other party with a contradicting interest, perhaps. So, was that part of the motivation of having only managers? Okay.
Yes, it was. I will tell you that the Department of Public Health in Massachusetts is very stringent, and I really respect them for it. Every year, we have to do a 90-page report on interpreter services to the Department of Public Health. So, because I had 9 hospitals in Massachusetts, I had to do 9 of them, and they're very data driven. So, we would invite them to be guests, but we actually had a vendor that offered us $10,000 to be able to present to us because he had all 75 hospitals in Massachusetts present. And we said no
Hmm.
because we did not want to have any conflict of interest.
Mm-hmm.
So, we have like a little email distribution list. We, pose questions to each other all the time, but it's really, really a phenomenal group of people that I still love to call my friends, and they are. The only thing is, regretfully, when you leave your position of management for language access, you have 6 months membership. If you don't find another position, then you no longer can participate, which makes sense, right? Because right now I'm a healthcare consultant, right? I do this nationally. Why would I still have the right to stay on the group if I'm really maybe becoming a conflict of interest myself, right?
Mhm.
So, very, very good group. And I'm very, very proud of that. But, that was like something like an organization that I was able to form. But some of the things that left me as I was reflecting back on the years and what I was able to do with the help of my team, one of the biggest things that I did was an interpreted dispatching system that really changed my world. I put it into place in 2011, and it allowed me to go from an average of 18-minute response time from the time we got paged, because yes, we were using pagers then, to less than 6 minutes on average uh, when I left in May of 2022.
Wow.
So, this was a company with a very good founder, Hans, who had become a dear friend but passed on, but the company's still going strong. And it really allowed me to make sure that my interpreters were as productive as possible without creating more work for them. So basically, the clinical staff or whoever would enter a request almost like on orbits. It will ping on my interpreters' iPads, and within 30 seconds, if it was 6 Spanish interpreters in-house, the first available one would accept it, arrive, and complete the case. And it was really phenomenal, to the point that other departments like housekeeping, transport started using it as well. So that was one of the most positive ones that I had. It allowed me to really help my staff be as productive as possible without losing their mind. And then the other thing that it also was something that I got a lot of joy in, though not initially, because initially I hated it, was the Section 1557 requirement to make sure that you vet the clinical fluency of all bilingual staff.
Mhm.
When I started that process, I was black and blue from being beaten up by doctors and nurses for at least the first 6 months. They were fighting against it. They didn't understand why their, 2-week course of Spanish wasn't good enough to communicate with patients, and to be honest, the passing rate was 48%,
Wow.
which should not surprise anyone. Being fluent in a language does not equate to you being clinically fluent.
Correct.
So, for instance, if I, as an English speaking doctor, can talk to you as a patient about your A1C for diabetes, and I can talk to you for 20 minutes, how come when I'm speaking in my Spanish, it becomes, hey, you got a lot of sugar in your blood, you too much sugar, stay away from sugar. I mean, I'm being facetious, but
Mhm.
basically it's not the equal information. It's not even close to it. So I feel like
Exactly.
our patients are much better served as a result of this. And we're ahead of the game because, as you know, with the new changes that are coming up with Section 1557, it's going to be completely, it's still required, but there are going to be consequences if people are not following it.
Oh.
Um, but I will tell you that the best cost saving thing that I ever did, and it was also a great quality improvement thing, was working with my LSP partner to establish my own video call center through their platform. And I'm not sure if you do that at all or not, or what you offer, but this was many years ago. It's going to be 8 years now, but that I had done this, but it was incredible because it really allowed my interpreters to, in between in-person calls, be able to take OPI calls and video calls seamlessly.
Mhm.
And, at first they were like, oh, I don't know if I want to do this, blah, blah, blah. This might take my job away. And I kept saying, the only thing that's going to take your job away is if you don't embrace technology, because we are not even doing cardiac surgeries the same way we did a year ago. We have to change with time. And, we can do all three, but we need to be ahead of it instead of react to it. So, in Massachusetts, for example, we had 9 hospitals. One of our Boston hospitals had a high population of Russians. So we had Russian interpreters on staff. If another one of the sister hospitals 40 miles away needed Russian, when they pressed on the iPad, it would literally connect to my Russian interpreter first. If that Russian interpreters were not available, then it would go out to my vendor.
Mm-hmm.
So it wasn't just from one hospital inside that hospital, but it would allow me to even connect with my resources at the different hospitals in my healthcare system. So that was phenomenal because it gave my interpreters great experience, a great understanding of what it's like to be a remote interpreter, which I think most of our remote interpreters do not get the respect that they deserve because it's extremely challenging to interpret in person, never mind remotely, through a phone or through video. So it gave them a different perspective. And it was especially life saving when we ended up with a pandemic. People actually asked me in my hospital if I had planned for it. And I'm like, planned for the pandemic? What are you talking about? Because everything was a turnkey. I ended up staffing the interpreters 24/7 because, as you know, even our LSPs were struggling because of the demand, right? The volume. And I was able to do that, which allowed them to do in-person cases, but also be able to help in that way, which was safer for not just them, but for the providers and the patients. And we ended up doing, I think, 52% of the calls we were intercepting, and our LSP partner was doing 48% at the height of the pandemic.
Wow. Yes, no.
So that was fantastic.
Yes, no, it sounds like a great idea at a time when this wasn't even happening on a regular basis. And to
Correct.
answer your question, yes, we do offer video remote interpreting, telephonic interpreting 24/7, and we love to help especially organizations that are small, that are trying to do the right thing by their patients or their clients, and so they connect with us through a subscription based model that we have. We at the moment are not tackling the large hospitals,
Right.
but we're bringing that technology to the smaller organizations so that nobody has an excuse to say no to a limited English proficient person. So that's our vision right now, is to
I think
collaborate
that's
with.
wonderful.
Mhm.
And on top of it, none of us are saying that you shouldn't have in person or you should only have remote or, I really honestly believe that we need all three modalities to be successful.
Absolutely, you
Because
have
you've
to.
got to
Mhm.
choose which one is right for the situation, right? You don't
Exactly.
necessarily want to do a SANE exam, a sexual assault nursing exam, by video if you can help it. I mean, sometimes you just
Exactly.
can't help it because the language is not available. Or
Mhm.
the one interpreter that's available actually is a male and resides in that survivor's own community and goes to church with her. You don't want that. You want to make sure that it's, as quick as you can get one, as safe as you can get one, and that the quality is good. So, I commend you for working with the smaller organizations who always get lost in the shuffle.
That is so important, Carla, what you're mentioning. And thank you. That mentioning that you need to assess the situation. I think that the tendency sometimes is to say, and I've heard this from hospitals in my area. I am located in Baltimore. Some major hospitals might just do OPI, VRI because that's what saves cost, as opposed to really assessing what is the situation calling for. So I think that one size fits all kind of solution is the wrong approach when we are talking about interpreting. We need to use all the different modalities. And just to say, talking about all technology and feeling like a fossil, I actually, when I was working as an interpreter, got to work with a robot. This was way before VRI and OPI. We actually drove a robot to the ER. It was very funny because the robot would just scare people because it was this standing thing going around. And at the end, we had to go to the station where the robot, so it was driven with a joystick, and then I would park it and then wait for someone to go by to whom I could tell them to plug me in. So it was scary, it was
Yeah.
funny. Anyway, it was it's now all technology, but back then was like the newest thing. And so it is important that interpreters adapt to technologies, that they don't that we don't refuse the technology simply because we think, oh my God, maybe this is going to put my job in danger, but rather embrace it and see how we can use it more effectively.
Absolutely. And if you think about it for a moment, I mean, look at what we're doing right now. We're doing podcasts. Podcasts have been probably around for a while, but not to the level that they are now, right? Look at all the
Exactly.
Zoom things. I mean, think about all of the, like the webinar that the National Council just had on health literacy. Well, if we did this as an in-person meeting, we maybe at best would have gotten 20 people, but we were able to have 168 participants from all over the country and Thailand. So it's
Wow.
like, even though it's less personal in some ways, and, I like the personal touch, um, an interpreter on video or OPI cannot reach out and touch the patient's wrist or elbow or give them more assurances, right?
Mm-hmm.
But at the same time, if you ask patients, which I have in focus groups, would you rather wait an hour for a Somalian interpreter to come in, or would you rather be attended to by video or phone? Hands
Immediately,
down,
right? Mm-hmm.
immediately.
Mm-hmm.
Because first of all, as a professional, as a healthcare provider, I want it immediate because I don't know what's happening with them, and it could be something critical. But who the heck wants to spend any more time in a hospital than they need to? If you go in with bronchitis, you'll come out with, 16 other diseases because you're
It's true.
exposed to everything, right? So I think that, do patients prefer in-person interpreters? I think if it's a patient that knows the hospital, comes to the hospital frequently, there's nothing like a relationship of trust that they build. Whereas sometimes the remote interpreters are different ones each and every time. So there's continuity more likely with a hospital in-person interpreter, but at the end of the day, effective communication needs to take place. And I always say to those providers, I have people that will say, "Oh, no, honey, I'll just wait for one of your interpreters." And I'll say, "Well, this is not a question about what is more convenient or what you would like to do. We have to provide the most efficient, fastest communication for this patient, because they could be in pain. And why are we holding off for 15 minutes, 20 minutes? Or there could be something that they want to tell you that is very urgent, and yet you're kind of like prefer waiting for the in-person interpreter." And,
Yeah.
in times I've been challenged, I mean, like literally challenged, like literally spitting in my face because they're so hot under the collar, the doctors or the nurses. And I would always respond and say, "Listen, I drive a Toyota hybrid RAV. Would I rather be driving a Tesla? Yes. Does my Toyota get me where I want to go? Yes." I said, "You've got to do what's not what your preference is, but what the right thing is for the patient."
Exactly.
You know, but then again, let's say it was a sexual assault, or let's say it was a behavioral health assessment, or, maybe end of life. Then maybe, depending on the circumstances, you definitely want to wait for the in-person interpreter. We use a
Yeah.
lot of dressings and band-aids in healthcare. You don't use the same dressing for every wound. You assess it, and then you determine what you're going to do with that wound. It's not a one size fits all.
Absolutely. Very well said. So this brings us to the topic of compliance and the key elements in healthcare. Um, what are those elements in healthcare that we can discuss as it relates to language access laws?
Well, there are so many. We could do a podcast just on
Just
we
on
could
that,
do
right?
5 podcasts and break them up into each. But I mean, I think the first thing that I would advise any of my colleagues that are out there saying, "I don't even know where to start. I really feel like I don't know what I need to know," is you have to take ownership about educating yourself, and then educate yourself again and again and again, because things change. And if you can't be that credible expert on language access, then who's going to be? Are you going to wait till the risk manager tells you something that may be completely contrary to what you should be doing, because they themselves don't really know? So you really need to get other professionals, do the webinars. Most of these webinars, like the ones from the National Council, are free. CHIA is free. There are lots of webinars and educational opportunities that are free from the hospital associations. Listen to podcasts like this, right, to keep more informed.
Mhm.
But you really need to find your allies. So you have to find your allies, and nurses are the ones that interact most with our patients, right? So more than any other discipline. So I would say find a doctor champion, work with the nurses, risk management, compliance, HR, your diversity officers, are invaluable. But don't forget my most invaluable colleagues, which were from environmental services. And
Mm-hmm.
people will say, what? Wait a minute, environmental services, how do they come and play into this? You just mentioned all of these other people. How do they fit in, right? But these are people, as you and I both know, a lot of them are immigrants themselves, right?
Yes.
And they're working in environmental services and they become the invisible ones. And I hate that term, but it's true. People see them, but they don't really see them. So the person's in there mopping the floor with the nurse talking to the patient, etc. And they're a witness to everything that's happening, but no one really pays attention to them.
Mm-hmm.
And I really spent a lot of time building relationships with them so I could meet with them and say, what do you see? What can we improve on? What are the things that you feel that we could do better? And you would be amazed at the things that they told me. I mean, amazed, you know?
Can you give us
And
an example of
I, I
one of
mean,
those things?
I'll give you a couple of examples. I mean, one of them was, just about the change of shift. At change of shift, they have this new thing that's called a change of shift report. In the old days, when the fossils roamed the earth like me, and I was doing nursing bedside, they would literally sit down with you, and you'd have this flip chart cardex, and they'd give you a report. Now they go to the patient's bedside, the nurse that's leaving the shift and the nurse that's coming on, and they give a mini report on the patient right in front of the patient, right?
Mm-hmm.
Isn't that wonderful? So inclusive.
Mm-hmm.
So the patient's actually hearing, oh yes, Mrs. D'Souza has a chest x-ray scheduled. I think they're going to come take her tonight. Then the doctor's going to come in tomorrow morning. She's due to be discharged, blah, 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 right?
Mm-hmm.
So imagine what's happening. So in an attempt to make this more inclusive and make the patient the center of it, with patients who are deaf and hard of hearing at LEP, the same conversation takes place, but in what language?
Mm-hmm. English.
English. So what does that do to your mother that's sitting there having them point at her, talking about her? She's now thinking she's dying. I got to be
Right.
dying because look, there's two of them here. I can't get one to answer my call bell, but now there are two of them in here, right? So,
Speaking about me.
yeah. So again, this came from somebody in environmental services that said to me, I don't know what the sense of that is.
Right. No, excellent point. Yeah.
And, and then the nurse laughed and she goes, I know I'm not supposed to, because she could speak both languages. And she said, but I almost felt like I had to go explain to the patient what was happening. So I told the patient, this is something they do with every patient, but that I was going to call an interpreter. But you see, that was one example. But another example was something relatively benign. But, we had a very busy hospital in Brockton, Massachusetts. And in the front lobby, there were two bathrooms, one stall bathrooms, and this is the days before we really did gender neutral bathrooms type of thing, right?
Mm-hmm.
But the woman's room was always having a line, right? And there was a changing table in the ladies' room. And then the men's room was always empty. So one of the housekeepers came up to me and said, hey, why can't we just make it so that it's, men or ladies, and we put a changing table in that one as well? Well, this was a phenomenal idea
Yeah.
that we were able to make happen for less than, I think it was $75 at the time, between the changing table and the $8 sign. Right. But this is what I'm saying is like, these folks are often marginalized and they dismissed when in essence, they were our heroes during the pandemic. They were front line. They were putting themselves at risk, cleaning out those COVID rooms and everything else. And, how soon people forget that all of us are an intrinsic little component that makes the healthcare chain be as strong as it could be.
And I think that inclusivity is really what we need when we are creating any type of project. You are mentioning the cleaning services that are giving you these ideas, for example, right?
Mm-hmm.
And anybody really is going to have a piece of the pie in terms of a broader perspective. So I really think that whenever we are creating a project that could potentially involve anybody in the hospital, like
Get them at
language
the
access,
table. Get them at
they
the
should get
table.
at the table. The security guard, the environmental services, anybody that could potentially face a limited English proficient patient, they should be at the table
So
because they
so
certainly will
here's
have something to say.
So
Mhm.
here's what I will tell you. Sometimes as a consultant, I do gap analysis. So I go into hospitals or healthcare centers or clinics, and I literally will identify, from a compliance, Joint Commission, DNV perspective, DPH, DMH, Department of Mental Health, you know, this is what you do well, and this is where, your signage is lacking. Your door isn't working for disability, blah, 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 blah. And I'm able to do that, give them that perspective. But I literally do something that I call a room service walk. And I learned this from a president of a hospital that used to work for the Four Seasons. And they used to have royalty from the Middle East come and visit this particular Four Seasons in Boston. And what they would do, he would say, before they arrived, would walk from the parking lot, from the, front door, all the way to their room to see if I could see anything that was out of line, a piece of paper on the floor, a tray outside of somebody's door, or whatever else. I feel it's equally important for us to put ourselves in the patient's shoes and come in and try to find mammography when you've been told that it's, an x-ray of your breast. No one ever used the word mammography with you, so you don't even have a reference. Even if you could read, in English, you don't even have a reference for what it is. So I think you need to be put in the perspective of the patient and go through the patient journey at all aspects before they come to the hospital, after they leave the hospital, the center, or whatever else. But, I think it's so overwhelming to people. Like, where do they start? And you just have to start. It doesn't matter where, just start. You
Just
know,
start.
just
Hmm.
start. Just get yourself on, join organizations like TAHID, IMIA, the National Council on Healthcare Interpreting, CHIA, whatever. It's not a lot of money, to join these places. And in most cases, the hospital will reimburse you. But there's so many free trainings since COVID. Like, I mean, honestly, like I was doing webinars like almost every other day during COVID because I felt that I could improve my knowledge skill set on so many different topics. You just have to look for them and devote the time.
And who do you have in mind when you say like join these organizations?
Like, I think the managers, I think
The
interpreters should
managers,
too,
yes.
but the managers should. So if I'm the manager and I'm supposed to be the leader of the group, then I would feel like I want to go back to my organization and say to them, well, you know what? I don't think we're prepared for Section 1557. Or do you know that the Joint Commission has new regulations on health equity and that you actually have to choose a health equity measure and report out on it every year?
Hmm.
Like,
Right.
you need to kind of be able to talk the talk so that you can do the walk. And
Absolutely.
if you're talking to nurses, you've got to talk a certain way. If you're talking to doctors, you got to talk a certain way. If you talk to risk management or to any leadership, you've got to know your risk management facts. I used to love it when Joint Commission would come, or DNV, which is the other accrediting body, because at that time the hospital will be willing to do anything, translate signage, translate documents, anything, because they don't want to get dinged by Joint Commission. So
Exactly.
I would take full advantage of that, right? Why wouldn't you?
Absolutely,
But you,
yes.
you need to know the regulations to be able to reference them, or else you're just blah, 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 blah. There she is
Exactly.
again. Yeah, blah, blah,
Yeah,
blah, blah.
you wouldn't have arguments to make your point unless
Exactly.
you join all these different groups that
Right.
talk.
Exactly.
It's just speaking about talking another language, right? They talk a specific language that management would understand, that the people that manage the money
Yeah.
would get,
Like,
right? Risk management.
exactly. One
Hmm.
of the biggest challenges is budget. I mean,
Hmm.
honest to God, if I had to get called into one more budget meeting, I would have literally like poked myself in the eye with a pencil. It's always do more with less, do more with less. But that's what healthcare has become now. There's, less reimbursements. Now we're not getting reimbursed if somebody comes back to the hospital in less than 30 days for the readmitted. And of course, the first thing they try to eliminate is the departments that they don't understand. So they only see
Right.
interpreter services and language access as hemorrhaging money. They don't see it as saving money and
That's
saving
saving money, yes.
liability, etc. So as a language access manager, you should be able to, not go in there with a full battle armor and like with a war cry, but you should be calmly able to say, well, you're going to pay for it one way or the other. You choose. and you're going to lose patients, and your providers are not going to be satisfied because now they have to wait to be able to start that OR case. And every minute in an OR that's delayed is over $200 worth. So, if you're waiting for an interpreter because you don't have the right setup, you don't have the right LSP, you don't have the right equipment, or you don't have the right staff, you got to take all of this into consideration, right?
Correct.
So,
And and that is why the next question is so relevant. As you said, language access is often seen as a hemorrhage, right?
yep.
Where would it be the right place for language access to be? And just to tell you a little bit about my experience, when I was working as an interpreter for the Johns Hopkins Hospital, we were below international patient services. So
Mm,
even though we work with the community, meaning the local patients, we were under the international department. But I always wonder if we would be better off under, let's say, patient safety or any other department within the hospital to try to convey a message that it wasn't only the international patients, or that it was a more a wider kind of need.
yep.
What do you think about that?
Well, I see a lot of my colleagues be under, for those that still have international patients, not some of them have shut down, but follow the money. With international patient clinics, there's a lot of money to be made. I remember visiting a hospital down south whose whole interpreter budget at the time, and this was, at least 18 years ago, was about $1.1 million. And it was all obtained from one patient coming into their international clinic, right? So,
Yes.
follow the money, but that's not the reality of what most of us and our patients deal with. They're here, they're working at sub minimal wage work in some cases. They're underinsured, uninsured. So to me, I would say I've reported to marketing. Okay. I reported to HR, which I would go to these meetings and they would be talking about Blue Cross Blue Shield and the cost of the benefits and blah, blah, blah. And I'd sit there like, oh my God, what's this got to do with me, right? Unless they needed to enroll bilingual employees, then I could be of assistance, right? I've reported to the chief medical officer and I've reported to nursing. And by far for me, the best fit was nursing. And it's not because I'm a nurse. It's really a strategic move. If you can be under patient care services, not necessarily patient safety or risk, because
Mhm.
that's very narrow focus.
Right,
And
especially, and not all the hospitals may have a
yeah,
department fully dedicated to patient
yeah.
safety. So, good point. Yeah.
Yeah, but
Mhm.
even risk management, they all have a risk management, but risk people who are my best friends, really, in most cases, they tend to be very narrow in their focus. So they can be good allies, but they can also be like almost afraid to make the wrong move because it could be too much liability, blah, 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 blah. So I think with me, strategically, it would be nursing because then you can really, really make an impact because they carry a lot of power. They're the people that touch the patients the most, right? So if you can become part of the leadership meetings, go to the leadership meetings, you'll hear, well, we're opening up a unit for transitional care. We're doing this, this, and that. And then you can say, oh, you're going to need iPads and you're going to need phone jacks and you're going to need this, 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 and that. Have you considered the translations? What documents are you looking at, right? But everything starts and ends really with nursing in so many cases. So from policy development to orientation to mandatory educations to patient grievances, you'll be right in the midst of Joint Commission prep, a DNV prep, and they have a lot of clout. So if you want to be part of that and you report to nursing, you better make sure you talk the nursing talk and you also know what's important to nurses.
That is such an enlightening position, Carla. And in fact, it makes me realize why, when I created the course on effective inclusion through language access and proposed it to the University of Maryland, Baltimore campus for the graduate students in nursing, pharmacy, dentistry, social work, medicine, and the School of Law, the first ones to actually be very responsive to this proposal was the nursing school. And the arguments were along those lines. It's like the nurses are the ones that are from beginning to end with the patient. So you made me realize why they are so interested in this training.
And listen, it's like, how at least my mom used to always say this, to the outside world, my dad was the boss. It's a Portuguese culture, right?
Hmm.
But to the inside world, we all knew who the boss was. It was my mom, right? My dad knew that clearly. So again, it's like, who makes the decisions? One thinks that the doctors make the decisions, and I honestly think they do on paper. But most of the doctors that I have worked with will always say, a lot of the doctors will say, I would have lost my license if it wasn't for the nurses. Because they're
Yes.
the ones that really know the patients, and they're the ones that alert them to anything that's going wrong or make recommendations and suggestions. And yet we are all a team, right? And the days of where the doctor was the doctor, I think are a little bit falling behind us, in the sense that most doctors in today's world, my experience is that they're very open to this team mentality, this team, collaborative team, because in all honesty, they can't do it by themselves, because they have less and less time with patients, not because of their own choosing, just because of the nature of things, right? So we all have to kind of like help each other out, or else we're going to really put our patients and ourselves in jeopardy.
In fact, that was demonstrated about 20 years ago when this patient that was a child, I think her name was Josie King. I'm not sure about the name, but she died at the hospital, basically because they didn't have all these safety procedures in place. And that's how the Department of Patient Safety came about, was to try to prevent this kind of medical errors. And I think part of what part of doctors' openness today to be more team oriented comes from the fact that they understand they cannot possibly do it all. They cannot ensure safety at every single step of the process, and they need to get all this feedback from all these different professionals. So yes, I completely agree with them. Yeah.
I
Mhm.
absolutely agree. I do too. And I mean, there's still some real arrogance in healthcare, right? So let's not be delusional. But even
Yeah.
interpreters, our interpreters, as we heard today early on the webinar for health literacy, imagine a world, as Alison Caballero, who was one of our panelists, said, imagine a world where you can actually say to a doctor or a nurse, excuse me, the interpreter would like to suggest that we do a teach back, because we just relayed a lot of information and I want to make sure that I interpreted everything correctly.
Thank you for listening to our first installment of Carla Fogaren's interview. You've made it this far. Let's listen to the second part of an amazing interview with Carla Fogaren. See you in the second part of this episode.